Myocardial Protection. www.anesthesia.co.in anesthesia.co.in@gmail.com. Myocardial Protection refers to strategies and methodologies used either to attenuate or to prevent post-ischemic myocardial dysfunction that occurs during and after heart surgery. Multiple factors: pre-CPB hemodynamic stability, cardioplegic techniques, success and adequacy of surgical repair, separation from CPB, hemodynamic stability in early post-op, pre-existing systemic and myocardial disease, preoperative factors, intraoperative factors, postoperative factors, preoperative factors, adult versus pediatric CAD versus valve HD, pre-op hemodynamic stability, ischemia/infarction, arrhythmias, hypotension, intraoperative factors, anesthetic, hypovolemia, LVDIS, arrhythmias, tachy, height, inadequate ventilation, direct manipulation, mid-cab, op-cab, postoperative factors, adequate ventilation, avoid vent distension, avoid vasospasm, maintain hemodynamics, control bleeding, maintain CBF 15 to 20 minutes following normothermic ischemia, total diastolic arrest from cell membrane depolarization, myocardial contracture, stone heart, vacuolization of SR, mitochondria, release of lysosomal enzymes, uncoupling of oxidation and respiration, sequester calcium/expel hydrogen, depletion of ATP less than 50% of normal level, irreversible lethal cell injury, glycolysis is blocked, increasing cellular acidity, protein denaturation, structural, enzymatic, nuclear changes, hibernating myocardium, moderate and persistent reduction in myocardial blood flow cause diminished regional contraction, non-contractile. Metabolic processes remain intact, viable. Decrease in the magnitude of the pulse of calcium involved in the excitation-contraction process. Inadequate calcium levels in the cytosol during each heartbeat. Stunned myocardium, severe reduction in myocardial blood flow. Function of the myocardium remains impaired, stunned, for a certain period despite re-establishment of flow. But full recovery is expected. Process occurs over a period of 1 to 2 weeks. Contractile proteins recover if the myocyte is reperfused before irreversible damage. Myocardial injury. Factors: ischemia, ventricular distension, tachycardia, hypertension, hypotension, fallen DPTI, TTI ratio, ventricular hypertrophy, reperfusion, pharmacological measures. Hypothermia and potassium infusions, the cornerstone of myocardial protection during unpumped heart surgery. Many other cardioprotective techniques and methodologies available. The ideal cardioprotective technique, solution, and/or method of administration has yet to be found. Myocardial O2 demand: 75%, 50%, 10%. Non-cardioplegic techniques: intermittent oxygen plus VF plus moderate hypothermic perfusion, 30 degrees Celsius to 32 degrees Celsius. Quiet field, during ventricular fibrillation. Avoids the profound metabolic changes that occur with more prolonged periods of ischemia. Duration of fibrillation till completion of distoles. Heart defib, proximals using an aortic partial clamp. In 1992, Bonchak et al. 3,000 pints of CAB. Elective operative mortality of rate 0.5%, an urgent mortality rate of 1.7%, and an emergency rate of 2.3%. Inotropic support was needed in only 6.6%. 1% required IAB. In 2002, Racco et al. 800 Pines Cab. Mortality minus 0.6%, 3.1%, 5.6% in elective, urgent, emergent groups. Intermittent oxcl is a safe technique both in elective and non-elective PTS when performed by an exp surgeon. Systemic hypothermia and elective fibrillatory arrest. Systemic hypothermia, 25 to 28 degrees Celsius. Elective fibrillatory arrest. Maintenance of perf brave at 80 to 100 mm of mercury. Surgical field may be obscured by blood during revascularization. In 1984, Atkins et al. Reported a low incidence of perioperative infarction, 1.8%, and a low hospital mortality rate, 0.4%, in 500 consecutive patients using this technique. Continuous coronary perfusion. Continuous blood perfusion of empty beating heart. Aortic root/ostial infusion. Used in op-cab. Unsafe for open heart. Continuous retro plus oxclo open heart, cardioplegic techniques. Cardioplegic solutions. Crystalloid cardioplegia. Blood cardioplegia, cardioplegic principles. Immediate arrest. Rapid infusion for 2 minutes. Hypothermia. Substrates, glucose A/adenosine. Maintain pH. Bicarb/tham/blood. Free radical damage. Mannitol/deferoxamine/LDBC/allopurinol. Edema, mannitol/glucose/albumin. Cardioplegic delivery. Antegrade route. Advantage, immediate cardioplegia. Problems. Impaired perfusion beyond obstruction. AVI, also in mitral surgery as aortic root distorted on atrial retraction. Hypertrophied heart. Retrograde route. Advantage. Better septal cooling. Cardioplegic solution perfuse beyond stenosis. Problems. RV not adequately protected. Risk of coronary sinus perforation, myocardial hemorrhage, edema. Infusion pressure kept less than 50 mm of mercury. Antegrade plus retrograde. More prompt arrest. Better distribution of solution. Hypothermia basal metabolism. In the absence of myocardial contraction, the myocyte still requires oxygen for basic housekeeping functions. This basal cost can be further reduced with hypothermia. Hypothermia normothermic arrest, 37 OC 1 ml/100 grams/ minimum 90%. Oxygen demand reduction. Normothermic arrest, 37 OC 1 ml/100 grams/ minimum 90%. Hypothermic arrest, 22 OC 0.30 ml/100 grams/ minimum 97%. Hypothermic arrest, 10 OC 0.14 ml/100 grams per minute 97%. Hypothermia decreased metabolic rate. Ischemia, intracellular pH. Non-ionized, ionized substrate ratio. Ni substrate escape out of cell. Hypothermia Ni ratio. Semi-liquid to semi-solid membrane. Calcium influx. Glutamate release in brain. Ca sequest. Hypothermia total extracorporeal circulation surface cooling. Surface cooling with partial CPB. Deep hypothermic total circulatory arrest. Low flow, profoundly hypothermic perfusion. All cooling for 30 minutes before starting CPB. Surface, less than 2.5 kilograms, small ascending aorta. Temp drops to 20 C. Problems of hypothermia. DHCA can cause seizures, stroke, change in mental status and muscle tone, post-pump choreathetosis. Neocortex, hippocampus, striatum. Loss of cerebral autoregulation less than 15 degrees Celsius. Coagulopathy, acidosis, enzyme dysfunction. Along with alkalosis, shift Borzoi dissociation curve to left. In a multi-center trial, continuous warm blood cardioplegia versus intermittent cold blood cardioplegia. Similar myocardial preservation, mortality, postoperative incidence of myocardial infarction, need for intra-aortic balloon counterpulsation, rewarming. Less than 10 to 12 degrees Celsius gradients between venous blood and water temperature. Also between arterial blood entering and core temperature. CPB withdrawn when bladder temp is 37 degrees Celsius. Prevent hyperthermia. Esophageal/pack temp not reliable. Alpha-stat method to correct pH. Probably better neuro. Outcome in profound hypothermia. Mediastinum flushed with cold saline. Reperfusion cell damage following ischemia is biphasic. Injury being initiated during ischemia. Exacerbated during reperfusion. Components: intracell COT2 plus overload during ISH and REPER. Oxidative stress induced by reactive oxygen species, ROS. Ischemia, endogenous antioxidant defense. Loss of cell membrane integrity. Conjugated DNAs are chemical signatures of oxygen-free radical lipid peroxidation. Ramaskinad, Rebecca I, Wilson G.J., et al. J. Molcell Cardiol 1987 19 to 289 to 293. Free radicals are generated within 10 seconds of reperfusion after ischemia. Zvyer J.L., Flaherty J.T., Wisfeld M.L. Proc National Akitsai USA 1987 84, 1404 to 1408. Reduce reperfusion injury. Reduce ionic calcium conc. In reperfusate. 1.0 mg/L, chelate with CPD. pH of 7.6 to 7.8. Reperfusate pressure 50 mm Hg and osmolality of 350 mosm. Reduce edema. Maintaining potassium arrest. Infusing at 37 degrees Celsius. Calcium regulation. Hallmark of reperfusion is Ca uptake. Post-ischemic failure of normal sequestration by SR, contractile AP. Calcium phosphate crystal deposition in mitochondrial matrix. Damage to respiratory chain and failure of ATP production. Other measures: antioxidants Vt, glutathione. OFR scavengers SOD, catalase, peroxidase, allopurinol, mannitol, CoQ10, deferoxamine malate. WBC filters, blood CP leukocyte filtration. Myocardial ischemia and reperfusion activation of neutrophils. Benefit of filtration in patients undergoing emergency CAG. Prolonged cross-clamping. Depressed ejection fraction. Heart transplantation. At least 90% of leukocytes must be removed to attenuate reperfusion injury markedly. Leukocyte depletion should be maintained for 5 to 10 minutes after the start of initial reperfusion prior to aortic clamp release. Filters remove more than 90% of WBCs. Controlled reperfusion. Reduce reperfusion after AC coral occlusion. Oxcal release blood CP given at 50 ml per minute per graft with a perfusion pressure less than or equal to 50 mm of mercury for 20 minutes into the grafts only. Cannulation of a side branch of the vein graft. Multi-center trial, the results were evaluated in 156 pints with acute coronary occlusion, reduced overall mortality from 8.7% to 3.9%. Complications of protective strategies. RV dysfunction. Rewarming, poor distribution, topical cooling. Coronary osteostenosis. Soft-tipped cannula/leakage around cannula. Endothelial damage to vein graft from hyperkalemic crystalloid cardioplegic. Coronary sinus injury. Infusion pressure less than 50 mm of mercury through sinus. Energy depleted heart cardiogenic shock/unstable angina. Pre-op stabilization with IOB, pharmacological support, MEC event. Prompt amino acid enriched warm blood cardioplegia. Followed by cold cardioplegia. both antegrade plus retrograde flow. Protection strategies under investigation. Ischemic preconditioning. Brief episode of ischemia slows the rate of ATP depletion during subsequent ischemic episodes. 1. Slowing of ATP depletion, or 2. Limitation of catabolite accumulation during the terminal episode of ischemia. Depletion of ATP could be slowed by a reduction in energy demand during ischemia, or by an increase in the net availability of high-energy phosphates. Brief periods of ischemia are known to cause prolonged contractile dysfunction, the so-called stunned myocardium. Preconditioning could effectively stun the myocardium. Reduce ATP utilization during the early phase of ischemia. Intermittent ischemia results in degradation of larger molecules. Breakdown products, lactate, H, NH3, inorganic phosphate, etc., are then washed out upon reperfusion. Limit catabolite accumulation during the occlusion. Alternatively, a reduced energy demand might drive anaerobic glycolysis to a lesser extent. Enzyme xanthine oxidase contributes to myocardial cell death by generating superoxide anions. Preconditioning, adenine nucleotide content of the myocardium. Limit hypoxanthine accumulation and superoxide production. Myocardial lipid peroxidation, estimated as MDA formation, is common during intermittent ischemia reperfusion. Heiser et al. Measured urate production by human hearts with CAD, net production of urate increased in ischemia. A reduction in catabolite accumulation can limit the osmotic load that occurs during ischemia. Another possibility is that preconditioning could limit accumulation of chemotactic factors that attract neutrophils to ischemic/reperfused tissue. Preconditioning can only delay cell death. Enough if sustained ischemic insult greater than 3 hours. Preconditioning failed to protect the mid and subepicardial myocardium. Second phase of protection required 24 hours to appear and sustained for up to 72 hours. Second window of protection, SWOP, late phase preconditioning, or delayed precond. Unlike classical preconditioning, which protects only against infarction, the late phase protects against both infarction and myocardial stunning. IP involves a complex cascade of intracellular events. Ischemic stimulus. Adenosine subtype 1, A1, receptor. Amplified. G protein and protein kinase C, PKC. Effector. ATP regulated potassium channel, GAATP. Protective effect, anesthetic preconditioning. A safer and simpler alternative to IP is pharmacologic intervention by inhalation anesthetics. APC shares the same mechanism of action as IP. The effect of inhalation anesthetics was present 30 minutes after discontinuation. Window of protection. During this time, which can last for 1 to 2 hours, there is an acute memory phase of preconditioning, anesthetic preconditioning. Isoflurane was administered in the precardiopulmonary bypass, CPB, period. The higher cardiac index in the isoflurane group is associated with a lesser degree of ST segment changes than in the control group. There was no significant difference between the two groups in the incidence of reperfusion arrhythmias. Dogs were randomly assigned to receive 2 ml drug vehicle, 50% polyethylene glycol in ethyl alcohol, control experiments, or glyburide, 0.05 mg/kg sup-1 administered intravenously, in the presence or absence of 1 MAC, in title, isoflurane in 4 experimental groups. Sevoflurane decreases the inflammatory response after CPB, as measured by the release of IL-6, CD11b CD18, and TNF-alpha. Total intravenous anesthesia was provided for both study and control groups by infusion of propofol, fentanyl, and midazolam. Sevoflurane 2% was added to the cardioplegia solution in the experimental group. Myocardial function after CPB, as assessed by RWMA and LFSV, was also improved. 1. Normothermic global ischemia lasting 15 minutes significantly augmented the adhesion of PMNs to the coronary endothelium. 2. This effect could be completely blocked by halothane, isoflurane, or sevoflurane continuously administered before and during ischemia and reperfusion at 1 and 2 mAq each. 3. Isoflurane given under control conditions without ischemia had no effect on basal PMN adhesion. 4. Administration of sevoflurane just at the onset of reperfusion was as effective as continuous application. 5. Suppression of the post-ischemic enhanced PMN adhesion by the volatile anesthetics was independent of their vasodilating potency. 6. The volatile anesthetics did not influence the severity of ischemic challenge, as judged by myocardial lactate release. Adenosine coronary vasodilatation immediate arrest. Ischemic preconditioning retards ischemia-induced atypical, delays onset of ischemic contracture, attend myostun, infarct size. Lipid peroxidation, SOD, catalase, glutathione peroxidase, glutathione reductase. Sodium/hydrogen exchange inhibition. Amiloride, caraporide, anaporide, zonaporide. Ejection fraction was greater. The resolution of regional left ventricular wall motion abnormalities tended to occur earlier, and the cumulative release of CKMB was less. Opioids. Hibernating animals use only 10% of their normal, active energy expenditure. Hibernation is a process mediated by cyclical variation in endogenous opiate compounds. Delta opiate receptor in particular is responsible. Hibernation reversed by opiate antagonists. Biological mechanism duplicated in humans, thereby inducing a profound state of energy conservation. Drugs with delta opiate activity confer myocardial protection, which is additive to cardioplegia. Myocard protection OPCAB. Short-acting beta blocker resmolol. Caraporide and apatinine associated with a marked attenuation of stunning. Conclusion. Ideal solution, technique, or delivery method has yet to be identified. Complexity of ischemia/reperfusion injury. Ideal protection is no longer limited to ONT. Need to develop new therapeutic strategies to protect the heart. Thank you. Thank you. Dr. Narendra to continue. Pediatric CPB immature handling of calcium. Immature myocardium can use carbo/AA/ketones/MCFA/LCFA. Hypoglycemia, hemodilution. Resistant to ischemia. Increased glycolytic capability. Decreased 5-nucleotidase. Increased ATP supply. Demand 100 LDPTI. Diastolic pressure time index. AL. DPTI, diastolic pressure time index. TDI, tension time index. DPTI. LA or PA wedge. TTI. Buckberg 1972. Protection strategies. Design of cardioplegic solution. Temperature. Electromechanical work state. pH. Metabolic substrates/additives. Protection techniques. Systemic hypothermia with VF. Ischemic arrest with hypothermia. Continuous coronary perfusion. Chemical cardioplegia. Coming off bypass problems. Systemic rewarming and aortic unclamping, tachy/fever/increased SVR. Rise in circulating catecholamines. More compliant heart. Greater LT. Acute withdrawal of CCB/BB. Coronary vasospasm. Elevated O2 rec. Of recovering myocardium. Solutions. Reinstitute bypass and ventricular distension. Optimize hemodynamic parameters. High-dose ionotropes better avoided. Adequate preload. Afterload reduction or IAB. Bleeding corrected. Failure to achieve separation. IAP/Valvide. Cessation of myocardial blood flow. Mitochondria. Cellular PO2 less than 5 mm of mercury within seconds. Oxidative phosphorylation stops. Cytosol. Anaerobic glycolysis. Glycogen. Glucose 6-phosphate. Pyruvate. Lactate. Cellular acidosis. Depletion of ATP.